wait for maybe 2-3 minutes to see, or you
No,
want to
ma'am.
start? You
Ma'am,
want to start?
start at
Madam,
right time.
there are
Start at right time, please.
8 cases, madam.
Yes, true. Yes, true.
Ma'am,
Okay,
start at
so
right time.
I welcome all of you to this clinical meeting, which is done under the umbrella of West Bengal Academy of Pediatrics. We are very happy today to have Burdwan Medical College presenting their cases to us, and Dr. Kaustubh Roy will be the moderator.
Hi.
Dr. Kaustubh Nayak, Dr. Kaustubh Nayak will be the moderator of this meeting today. We have a large number of cases, so Dr. Nayak, I think we have to be sure that we try to stick to time, and we want to try and finish in 1.5 hours, so about 4 o'clock.
Yes, madam. So we
Thank
are
you.
starting. Before that, I must tell that we are very much grateful to you or other WBAP for allowing us to conduct this session. So today we have 8 cases, and most of the cases are very much interesting. I think you all enjoy these cases. So we are starting. Our first speaker is Dr. Meenakshi Bhomik, and the case is tantalizing deflection from infection. So let's see what unfolds with his speech. So Meenakshi, please start.
Good afternoon, everyone. I am Dr. Meenakshi Bhomik, second year PGT, Department of Pediatrics, Burdwan Medical College and Hospital. I'll be presenting a case titled Tantalizing Deflection from Infection. A 1-year, 1-month-old male child hailing from Shuri, Birbhum, presented to us with chief complaints of difficulty in breathing for 7 days and cough for 15 days. The cough was insidious in onset, gradually progressive, associated with sputum, and there was no diurnal or positional variation as noted by parents. The difficulty in breathing also lasted for 7 days, insidious in onset and gradually progressive, associated with poor feeding. There was no history of fever, no history of bluish discoloration of skin, suck-rest-suck cycle, blood in sputum, and there was no contact history of TB. The baby was apparently normal till the age of 9 months when he had a fall from the stairs followed by a swelling around the right elbow. The mother incidentally noticed swelling and restriction of movement in the right hip region, which was evaluated at a local hospital. The child was diagnosed with right elbow osteomyelitis and right-sided septic arthritis of the hip, which was conservatively managed, and the child fully recovered. The child also had 2 to 3 episodes of lower respiratory tract infections requiring hospitalization and intravenous antibiotics for a week at the age of 7 to 8 months. There was history of bilateral ear discharge requiring topical and systemic antibiotics around 9 months of age. The child had been born out of second-degree consanguineous marriage. There was no family history of tuberculosis or any such similar illness. The antenatal, natal, and postnatal history were uneventful. The child was exclusively breastfed till 6 months of age, had been immunized till 1.5 months of age, and no further vaccination taken. The developmental history was appropriate for age, and the family belonged to lower middle class according to modified Kupusami scale. On general physical examination, the child was alert, aware of self and surroundings, but irritable. Measurement of vitals showed an increase in respiratory rate with a decreased saturation of oxygen at room air. On head-to-toe examination, the child appeared wasted. The mouth and oral cavity showed absent tonsils, pallor was present, and there was no cyanosis, clubbing, edema, or lymphadenopathy seen. On anthropometric evaluation, the length and weight of the child were below the 3rd percentile. The mid-upper arm circumference was 10 cm, which was less than normal. Respiratory system examination showed an increase in the respiratory rate with accessory muscles of respiration working. The left side of the chest was dull on percussion, and on auscultation, there was decreased air entry in the left axillary and infraaxillary area with bilateral crepitations. Rest of the systemic examination were within normal limits. A 1-year, 1-month-old male child born out of a second-degree consanguineous marriage with significant past history of recurrent lower respiratory tract infections, bilateral chronic suppurative otitis media, right elbow osteomyelitis, right hip septic arthritis, starting from the age of 9 months, now presented with complaints of cough and respiratory distress for a duration of 2 weeks. There was no history of fever or lymphadenopathy. Measurement of vitals showed tachypnea with decreased SpO2 at room temperature, room air. Head to toe examination revealed the child to be wasted with presence of pallor. Anthropometric evaluation showed the child to be having severe acute malnutrition. Respiratory system examination showed working of accessory muscles of respiration with decreased air entry in the left axillary and infraaxillary region with bilateral crepitations. Rest of the systemic examinations were normal limits. Based on the history and the clinical signs and symptoms, we sent the first set of investigations. Complete blood count revealed neutrophilic leukocytosis with decreased hemoglobin and raised CRP. Chest X-ray PA view showed left-sided empyema. We did a diagnostic pleural fluid tab, which was suggestive of exudative nature of the fluid. The pleural fluid culture sensitivity showed growth of enterococcus sensitive to vancomycin, linezolid, amoxicillin, and ciprofloxacin. On day 1 of admission, the child was having severe respiratory distress, and in view of impending respiratory failure, child was put on bubble CPAP. Surgery opinion was taken and left intercostal drainage was inserted. Fibrinolytic therapy with 3 doses of urokinase was given. Injection vancomycin and ceftriaxone were started after sending pleural fluid culture and sensitivity. Child responded to the fibrinolytic therapy and IV antibiotics. Injection vancomycin was continued for 14 days. Gradually, oxygen was weaned off and sequential radiographs of the chest showed clearance of empyema. In view of severe acute malnutrition, dietary advice was given and supplements were added. ENT opinion was taken in view of past history of ear infection, which showed tubotympanic type of perforation in the left ear and right ear could not be visualized due to active infection. So what have we got till now? A 1 month, 1-year-old male child with failure to thrive, having significant past history of bacterial suppurative infections. Therefore, we come to a probable diagnosis of immunodeficiency, which could be primary immunodeficiency disorder or a secondary immunodeficiency disorder. Secondary immunodeficiency was ruled out as mother's retroviral status was negative and there was no history of chronic immunosuppressive drug intake. To evaluate the primary immunodeficiency disorder, we sent an immunoglobulin panel which showed markedly decreased levels of all the 4 immunoglobulins, suggestive of hypogammaglobulinemia. Further, T cell and B cell flow cytometry was sent, which showed complete absence of CD19 positive cells. Therefore, we come to a provisional diagnosis of X-linked agammaglobulinemia. For further confirmation of diagnosis, we had referred the child after stabilization to a higher center, and from there, clinical exome sequencing was done. The report showed a hemizygous missense variation in exon 5 of the Bruton tyrosine kinase gene, which results in amino acid substitution of proline for threonine at codon 151. The phenotype of the disease was OMIM, Omin phenotype, which is characterized by X-linked agammaglobulinemia and isolated growth hormone deficiency, markedly reduced number of B cells, short stature, delayed bone age, and good response to treatment with growth hormone. Based on the above evidence, this Bruton tyrosine kinase variation classified as a likely pathogenic variant and had to be carefully correlated with the clinical symptoms. The child was started on treatment with intravenous immunoglobulins and has been planned on monthly doses of IVIG at the rate 400 mg per kg per day. Child was advised to continue oral amoxiclav at appropriate doses. Supplements were added. Proper diet was advised along with monitoring of weight. And child was advised against administration of any live vaccine like oral polio, MMR, live attenuated influenza. Since the genetic study revealed the disease to be of Omin phenotype, we have further planned during subsequent follow-up estimation of bone age of the child and level of growth hormone. Thus, X-linked agammaglobulinemia is a rare genetic disorder in which mature B cells are not generated and it's manifested by a complete lack of or very low levels of gamma globulins in the bloodstream. This condition is more common in the males and has an occurrence rate of 1 in 2 lakh live birth with a frequency of 1 in 1 lakh newborn males. The occurrence of mutation at the Bruton tyrosine kinase gene results in inhibition of maturation of B cell, hence results in decreased production of immunoglobulins in the serum. Patients affected by this condition usually present with recurrent infections, especially with extracellular encapsulated bacteria and in early childhood. This is the diagnostic criteria of a patient with X-linked agammaglobulinemia. This figure shows the inheritance pattern of an X-linked recessive condition of agammaglobulinemia. The chances of carrying an X-linked recessive disorder in every pregnancy, a female has a 50% of having a son who may be affected, and the chances of the daughters having one copy of the mutation is a 50%. Thus, this case is reported to emphasize on the fact that any child presenting with a history of recurrent infection should click a picture in the physician's mind to consider immunodeficiency disorders like X-linked agammaglobulinemia, which though rare can be the root cause. In recent times, it has been diagnosed earlier in life, which allows to initiate treatment earlier and pay more attention to the diagnosis and treatment of associated infections. Many children are now expected to reach adulthood, and hence we should carefully follow the child up till adulthood or even later. Thank you.
So, thank you, Minatri, for your discussion.
Thank you, sir.
So, another point is
Dr. Naik, we can't hear you. Become mute. Please unmute.
yes, sorry, madam. So we are going to next case, but before that, I have one request to the audience. If audience has any question, they can put those questions in the chat box, and all of them will be answered. So next case is a mystery with fever, and speaker is Dr. Amoresh Rai, and this is a very much important case. So start, Amoresh.
Dr. Naik, there's one question in the chat box. While it is being next case is coming up, can we take it?
Yes. So, was there history of delayed fall of cord in the answer? Writing in the chat box.
Any comments on expected prognosis of this case?
I also asked the same question. Any expectation of the prognosis of the case?
Yes, we are writing in the chat box. Answer of those questions we are writing.
Kaustubh, please start the second case.
Second case.
Hello.
We are,
Kaustubh.
some problem here.
Huh?
Start.
You start the second case.
Sir,
Respected teachers and all the delegates, I, Dr. Amoresh Roy, second year postgraduate training, Department of Pediatrics of Burdwan Medical College. I am going to present a case which is a mystery with fever. It is a 7-year-old Hindu female from Puga, Burdwan. The chief I, Dr. Amoresh Roy, second year postgraduate training of Department of Pediatrics from Burdwan Medical College. I am going to present a case which is a mystery with fever. It was a 7-year-old Hindu female It was a 7-year-old Hindu female from Burdwan. The chief complaints were fever on and off since last 5 to 6 months, generalized swelling of the body since last 4 weeks, with involuntary jerky movements since last 2 days. The fever was present since last 5 to 6 months with intermittent low grade in nature, initially subsiding with medications, but getting more frequently and high grade in nature over last 3 months. Fever was associated with polymorphic erythematous brownish maculopapular rashes, which started 3 months ago, initially over the trunk and extremities, and it spread gradually over last 2 months. This was also associated with severe generalized body ache and cramps, weakness of the legs in the form of clumsiness in walking. The child developed progressive swelling of the body, which started initially in the face and legs and later involved the entire body. The child was also passing low volume and high colored urine since last 3 to 4 weeks. The child was having abnormal jerky movements of the arms and legs with turning of head to one side with frothing from mouth lasting for 3 to 4 minutes, followed by loss of consciousness, which was happening since last 2 days before admission. The child was having painful ulcerative erythematous patch over the lower lips and buccal mucosa since last few days before admission. The child was admitted at hospital 2 months ago with ARI symptoms and ongoing skin rashes, which was treated symptomatically with oral antibiotics, topical emollients, and other supportive medications. The child developed exacerbation of these respiratory symptoms since last 9 days before admission. Regarding the past history, the child was apparently healthy before 5 months without any other significant illnesses. Regarding the immunization history, the child was immunized till date, and the child achieved all the developmental milestone as per age. Treatment history was regarding the treatment history, the child was being treated intermittently for ARI symptoms by the local physicians. The child was on MDI with bronchodilators and steroids since last 9 days before admission in the hospital due to exacerbation of the cough and other respiratory symptoms. No, there was no family history of any consanguineous marriage. There were two younger siblings who were apparently healthy, and there were no family history of asthma, TB, or any other chronic illness. The child belongs to a lower middle socioeconomic status according to the modified Kutusumi scale. The perinatal history was uneventful. Birth history was 2.7 kg at term, and feeding history was exclusive breastfeeding till 5 months, followed by supplementary diet. Regarding head to toe examination, the child was lethargic on admission. Weight was 32 kg, more than 2 standard deviation. Height was 105 centimeter, less than -2 standard deviation. Hair and nail were normal. Eyes showing mild conjunctival pedilimbal congestions. Pallor was present. Bilateral pitting pedal edema with periorbital and parietal edema was present. BP was 96 by 43 meter of mercury. Heart rate was 124 beats and with normal pulse volume. Respiratory rate was 34 per minute with thoracoabdominal type with mild intercostal suction. Temperature was raised 100.7 degree Fahrenheit. This picture showing bilateral lower limb edema and multiple polymorphic hyperpigmented rashes spread all over the trunks, extremities with few palpation. The respiratory rate was 34 per minute, thoracoabdominal in nature, no visible deformity of the chest wall or paradoxical movement with multiple rashes over the chest. On palpation, chest wall movement was diminished, vocal fremitas was normal. On auscultation, fine crepitation audible over the right mammary and inframammary regions. Breath sounds were equal and normal on both sides. On cardiovascular and CNS examination, there was no murmur, and jugular venous pulse was normal. All cranial nerve functions were normal. Brainstem function was normal, and Glasgow's coma scale was 14 by 15, and tone was diminished in all lower limbs, and power was 3 by 5 in both lower limbs and 4 by 5 in both upper limbs. Gait could not be assessed. On GI examination, the abdomen was mild extended, no shifting dullness was present. Liver span was 10 centimeter on right mid-clavicular line with sharp margin. Now, regarding the case summary on clinical history, it was a 7-year-old female child admitted to our institution with intermittent fever over last 5 to 6 months, associated with progressive polymorphic hyperpigmented skin rashes, with generalized body ache, slap gait, recurrent respiratory tract symptoms, with poor response to conservative management, along with dose inhaler and other supportive medications, and developed progressive swelling, oliguria, and high colored urine since last 3 to 4 weeks. The child was also having multiple seizure episodes, which was deleterious in nature, and since last 2 to 3 days, along with oral ulcers. On examination, the child was lethargic with anasarca, pallor, fever, tachycardia, tachypnea with erythematous brownish polymorphic rashes spread all over the trunks and extremities, and diminished power of the all four limbs with diminished chest wall movement with fine crepitations at intramammary and mammary areas, which was more in right than left. Now, what are the possibilities? We have thought about these possibilities regarding this child. Number 1 is miliary tuberculosis. Number 2 is HIV. Number 3 is vasculitis. Number 4 is collagen vascular disorders. And number 5 is malignancy. And we started workup after admission of this child. On day 1, we sent sepsis screen, which was showing a high ESR of 42 millimeter, and peripheral blood smear was normal, and all the viral markers were negative. After admission, the seizure episodes were controlled with IV anti-epileptic drugs, levetiracetam, with optimizing and securing the airway. PRBC was transfused due to low hemoglobin with monitoring of the urine output by catheterization. Moist oxygen nebulization with bronchodilators and steroid was started. Salt restricted diet was initiated, and hemodynamics was normalized. There is no episode of convulsion for 24 hours with normalization of the vitals, and we sent the following investigation. The LFT was showing low albumin, 2.6 gram per DL. Creatinine was high for this child, 1 milligram per DL. With CSF finding, we found that the cell count was 120 per cubic millimeter, and it was predominantly of lymphocytic in nature, and protein was raised, and glucose was normal. On day 5, we sent all the workup for infective etiologies, and the infective etiologies showed the serum IgM and IgG scarp types were negative. Mantoux test was also negative, and CSF culture showed no growth, and a CSF gram stain also showed no microorganism in gram smear, and no FBs seen in J stain. Gastric lavage was done for CBNet, which was also negative. Now the X-ray was done, which was showing diffuse opacity with few nodular lesions in the lower and middle region. As the child was having persistent temperature with lethargy, we sent the following workup suspecting UTI. And the urine REME showed albumin 3+ with nephrotic proteinuria, plenty of pus cells with plenty of RBCs, and urine culture revealed no growth. And the lipid profile was showing total cholesterol was high, triglyceride was also high, but urine culture was showing no growth. The child was also having oliguria since last 24 hours with poor response to fluid challenge. So we were suspecting that it may be a case of acute lupus nephritis, and we sent serum C3 and a HEP2 anti-dsDNA, which were also normal, and the creatinine was rising, was 1.2 milligram per DL with blood urea nitrogen 17 milligram per DL, and anti-CCP antibody was also negative. And we did USG whole abdomen to look for renal ecotexture and to look for liver parenchyma, which showed liver span of 11 centimeter, heterogeneous in ecotexture with presence of 1+ ascites and left-sided pleural effusion. Corticomedullary differentiation of the kidneys are given. And Doppler study of the lower limbs were done, suspecting deep venous thrombosis, and it was showing normal flow noted in bilateral arterial and venous systems. 2D bedside echo with Doppler was also done, which was also showed normal, and 12D DCG was also normal. Till now, the child, which was a 7-year-old female, having persistent fever with generalized rash, perilimbar congestion with oral ulcer, with progressive oliguria, edema, with proteinuria and hematuria. And the child was also having worsening of ARI symptom over last 8 to 9 days with radiological features of diffuse opacity. And the child was also having generalized tonic-clonic seizures with CSF studies showing elevated cell count and protein. After all these clinical features and after evaluation of these features, we suspected that it may be a case of vasculitis. So we did review of literature, and the possible systemic vasculitis we thought about were two. That were medium vasculitis medium-sized vessel vasculitis, and small-sized vessel vasculitis. Among medium-sized vessel vasculitis, there may be Kawasaki or polyarteritis nodosa, and among small-sized vessel vasculitis, it may be Wegener granulomatosis, it may be Behçet's disease, or it may be Hennoscoline purpura. After review of literature, medium vessel vasculitis, that is Kawasaki disease, was ruled out due to chronic progressive course of the illness without any lymphadenopathy, normal liver enzymes, and no discomative rashes, with presence of nodular lung infiltrates. And among small vessel vasculitis, Hennoscoline purpura was ruled out because of the progressive polymorphic nature of the skin rash without any diffuse alveolar hemorrhage or GI involvement. And Behçet's, which was also another type of small vessel vasculitis, that was also ruled out due to absence of recurrent painful oral ulcer or dental ulcer. Now the possible DDs in this child, that is polyarteritis nodosa, which is medium vessel vasculitis, but there is less possibility of progressive lung involvement in this case, although few cases has been found with interstitial pneumonia. And another possible DD was Wegener granulomatosis, which is a medium to small size vessel vasculitis. But here the in favor of this diagnosis were that it is for female child with age of onset at 7 years. Now, at day 8, the child was having persistent rise of temperature, and we sent the following markers of vasculitis, that is Sianka and Pianka, and Sianka strangely came out to be strongly positive, and the count was also high, which was 19,000. And then we did review of the literature, which was showing the following criteria should be present for diagnosis of childhood granulomatosis. That were: number 1, upper airway involvement; number 2, laryngeal, tracheal, or bronchial involvement; number 3, renal involvement; number 4, ANCA positivity; number 5, histopathology showing granulomatous inflammation; and number 6, proteinuria, hematuria, RBC fast, or necrotizing post-immune glomerulonephritis. So from this workup, from this review of literature, we plan for further workup, which were HSCT chest, USG guided renal biopsy, split thickness skin biopsy, and MRI brain with contrast to look for CNS vasculitis. Now our provisional diagnosis was systemic vasculitis, which was childhood onset Wegener granulomatosis. And further course of treatment, the child received pulse methylprednisolone at a dose of 30 mg per kg for 3 to 5 days, and cyclophosphamide started with other supportive medications after proper ruling out sepsis. Now regarding the case discussion, it is an ANCA-mediated vasculitis. It's a post-immune vasculitis characterized by small vessel involvement. There are 3 distinct forms of medium to small vessel vasculitis, which are Wegener granulomatosis, Church-Strauss syndrome, and macroscopic polyangiitis. Regarding epidemiology of this Wegener granulomatosis, it is also common in adult, but also occur in the children with mean age group of 14 years, with female predominance of 3 to 4:1. And pathology regarding this illness, this is a necrotizing vasculitis, is the cardinal feature of this disease, and kidney biopsy reveals crescent formation. Sometimes there may be formation of RPGN in these cases also. And the frequency of organ system involvement are at first kidney involvement, followed by respiratory tract involvement, followed by sinuses involvement, joint involvement, skin and eyes involvement. In our case, the child was having kidney involvement, respiratory tract involvement, and eyes involvement with multiple skin rashes. Thank you.
Thank you, Amores. So I think there are many questions. All questions are being answered in the chat box. Please go through the chat box. So we are starting our 3rd case. It is also a very interesting case, selling ambiguous tides. And speaker is Dr. Nandita Bhattacharya. Nandita, please start.
Good afternoon, everybody. Myself is Dr. Nandita Bhattacharya, second year postgraduate trainee in pediatrics from Burdwan Medical College and Hospital. Today, I am going to present an interesting case. The title of my case is Selling Ambiguous Tights. A 7 months old baby was brought to our institution for ambiguity in external genitalia since birth. The baby had no history of any major illness or hospitalization before this. The infant didn't have any dysmorphic facial features. There was no similar history in the family and no history of consanguinity. On examination, the vital parameters were as follows. Baby appeared alert and playful. Temperature was recorded to be 98.6 degree Fahrenheit. CRT was less than 3 seconds. Heart rate was 110 beats per minute. Respiratory rate was 36 per minute, abdominothoracic in nature, and blood pressure was 76 by 48 millimeter of mercury. All the vital parameters were within normal limit. On anthropometric evaluation, weight was 7 kg, length was 64 centimeter, head circumference and chest circumference were 44 centimeter and 43 centimeter respectively. All the findings were within normal limit. Head to foot examination, no abnormalities were detected. On systemic examination, which revealed no abnormalities. This photograph was taken and is being published here with due consent from the parents. Clitoris-like structure present with stretched length of 1.5 centimeter. Urethral meatus present on the undersurface of the clitoris. Scrotum-like structure with little rugosity present bilaterally. Right-sided gonad could be felt in right scrotal sac, but left-sided scrotum-like sac was empty. USG of whole abdomen, including bilateral inguinoscrotal region. The findings were normal right testis in right hemiscrotum. Left testis visualized neither in the scrotum nor in the inguinal canal. No Mullerian duct structure noted in the abdomen. No evidence of female gonads in the pelvis. And no intra-abdominal lump or tumor seen. As the ultrasonography was inconclusive regarding the presence of left testis, we planned for pelvic MRI, which showed left-sided testis was seen intra-abdominally near the deep inguinal ring as hyperintense signal on T2 weighted imaging and as hypointense signal on T1 weighted imaging. No Mullerian duct structure found in the abdomen. Karyotyping was done, which showed a 46XY karyotype with a terminal deletion of the short arm of chromosome 9 in 100% metaphases. Now, interpretation so far. Radio imaging studies revealed presence of a male gonad and absence of any Mullerian structure. Karyotype is 46XY, suggesting that we are dealing with a 46XY DSD, that is disorder of sex development, and under-virilized male. Now, what could be the possibilities in our case? Number one finding was 46XY karyotype. Number two, ambiguous external genitalia. Number three, testis present. Number four, no evidence of Mullerian duct structure. Number five, no features suggestive of adrenal crisis or salt wasting. Number six, no other congenital malformation. The possibilities are, it might be complete androgen insensitivity syndrome. Number two, it might be partial androgen insensitivity syndrome, Leydig cell aplasia, or dihydrotestosterone deficiency. Some biochemical parameters are being shown here. Serum electrolytes were sodium 139 milliequivalent per liter and potassium 3.9 milliequivalent per liter, which are within normal limits. Serum cortisol, that is 8 AM morning sample, was found to be 15.64 microgram per deciliter, which was normal. Serum LH was also normal, but serum testosterone was 39.05 nanogram per ml, which was quite high. Serum dihydrotestosterone was 2.44 nanogram per ml, which was low. Serum testosterone is to dihydrotestosterone ratio was 16. Now we planned for human chorionic gonadotropic stimulation. 5,000 international unit per meter square of HCG given as a single IM dose. Baseline laboratory values were noted prior to HCG administration, and blood sample for testosterone to dihydrotestosterone ratio was again drawn 7 to 2 hours after the single dose test. It came out to be 27. It was quite high. Normal children respond with ratios from 8 to 16. Now, what inference can we draw now? As plasma level of testosterone is high and LH level is normal, Leydig cell aplasia is ruled out. The external genitalia is not that of a female, vagina is absent, so complete androgen insensitivity syndrome is also excluded. Baseline high testosterone and low dihydrotestosterone level marked elevation in HCG stimulated Ts to DHT ratio is suggestive of a defect in conversion of testosterone to dihydrotestosterone. So our final diagnosis is 5-alpha reductase deficiency. Now, what are the challenges someone might face while dealing with a 46XY DSD? The etiology of 46XY DSD is not identified in up to 50% cases. The diagnosis of partial androgen insensitivity syndrome may be particularly difficult in infancy. This flowchart is showing steroid hormone synthesis. And in our case, the block is here, that is the conversion from testosterone to dihydrotestosterone. Now coming to a brief discussion on 5-alpha reductase deficiency. The disorder is inherited as an autosomal recessive trait but is limited to males. This is a rare cause of 46XY DSD. Exact incidence is unknown. This condition results in the inability to convert testosterone to the physiologically more active dihydrotestosterone. Decreased production of DHT in utero results in marked ambiguity of external genitalia of affected males. Now coming to the treatment part. Treatment consists of gender assignment, hormone replacement therapy, and surgical intervention. Hormone replacement therapy should be considered in children raised in male gender and is required in children raised as females after undergoing gonadectomy. In children with 5-alpha reductase deficiency who are raised as male, testosterone or dihydrotestosterone therapy may increase the penile length. It should be done in prepubertal male prior to hypospadias repair. Now, what are the take-home messages in our case? The main concern in children born with ambiguous genitalia is the gender assignment. Multiple factors should be considered before this. These include early diagnosis, appearance of external genitalia, surgical option for both cosmetic and functional outcome, potential for fertility, need for lifelong hormone replacement therapy, the particular social, religious, and cultural context of the family. The ultimate goal of the treatment is to restore the external genitalia as close to a non-ambiguous appearance as possible while retaining full sensation, the ability for sexual satisfaction, and fertility. Thank you.
Thank you, Nandita, for your discussion. So if you have any question, you can put in the chat box. We will answer those questions. Now we are going to our fourth case. Eyes speak louder than words. I think this is the rarest of rare cases. Very few of you have seen these cases. So let's see what happens with his speech.
Am I audible, sir? Good afternoon, my respected seniors and my colleagues. Today, I will be discussing a very interesting case under the heading of "Eyes Speak Louder Than Words." The photos and videos shown in the presentation were taken after proper consent of the patient parties. Our case is an 11-year-old female child from Burdwan who came to our institution with chief complaints of bleeding tears for last 1 month with intermittent episodes of bleeding from the nose for the same duration. The 11-year-old child was apparently well 1 month back since when she developed recurrent episodes of painless bloody tears with a variable interval of 3 to 8 days and each episode lasting for around 30 seconds to 1 minute. The onset was spontaneous and was first noticed when the child was having a conversation with her father. There was no history of any trauma to the eyes, neither did the child have any visual disturbances with the episode. The child also had 3 episodes of bleeding from the nose during the last 1 month associated with the course of the illness. There was no history of fever, purpuric spot, or bleeding from any other site during or prior to the course of the illness. After the first episode, the frightened parents had taken the child to a nearby government hospital and they admitted the child and did a basic investigations for coagulopathy, which came as normal. And the child was discharged the day after with a diagnosis of single episode idiopathic blood-thin tears. And the parents were made assured that it will not recur. But for the 1 month, the child had similar recurrent episodes and this time came to our institution. We admitted the patient for a thorough investigation of the underlying etiology. The child did not have any such similar episode in the past or bleeding from any other side. This was the first hospitalization episode for the child. Birth history and developmental history was normal, and the child was yet to achieve herd menarche. On general survey, findings was largely within normal limit. Pulse rate was around 90 beats per minute, and the systolic and the diastolic BP was 100/68, which is just below the 50th centile for the height and the age. Pallor was absent. Examination of the hematological system did not reveal any clues. There was no enlargement of the liver and spleen. There was no bony tenderness, and lymph nodes were not enlarged. Other system examinations are also within normal limits. So what we have a 11-year-old girl having recurrent episodes of painless bloody tears at a variable interval of 3 to 8 days with episode lasting for 30 seconds to 1 minute. There is also associated bleeding from the nose during the episode, and there was no history of any such episode in the past. There was no history of fever, purpura, or bleeding from any other side. Pallor was absent. General survey examination was the normal limit, and there is no abnormality found in the examination of hematological system. So from the examination and the history, we came to our provisional diagnosis of this is a case of bleeding disorder manifesting as bleeding tears and bleeding from nose. The differential diagnosis that we kept in our mind was bleeding due to local ophthalmological cause, mast hypertensive disorder, vascular disorder like Osler-Weber-Rendu syndrome or Hinox-Tonellin purpurea, and the last DD was Munchausen syndrome. From the day one, we started maintaining a blood pressure chart to rule out any mast hypertension. Preliminary blood investigation showed hemoglobin was 12.9, a platelet count of 1,22,000, and retic count of 1%. Prothrombin time, the activated partial thromboblastine time, and the INR was also within normal limit. That rules out any coagulation disorder. Peripheral blood smear showed normal RBC with no blood cell and adequate size and morphological platelets. The bleeding time and clotting time was also within normal limit, and that rules out all bleeding disorder, including platelet functional disorders. So at the end of day 4, we had ruled out all systemic causes of bleeding diathesis. So we decided to look for local causes. An ophthalmology and ENT opinion was sought for. On ophthalmological examination, the child had a visual acuity of 6/6 with healthy lids, clear conjunctiva, and cornea. There were no conjunctival telangiectasias. The ophthalmologist advised olopatadine antihistaminic eye drops and a CT scan of orbit to rule out any underlying pathology like SOL. We arranged for a CT scan of orbit and which was also within normal limits. Nasal cavity and the posterior pharyngeal wall was also within normal limits. There was no spar or turbinate hypertrophy. Nasal cavity endoscopy did not show any telangiectic vessels. So at the end of day 7, we are yet to reach to any etiological diagnosis. So as we are thinking this to be a case of factitious disorder, during day 10 of rounds, we suddenly found this urine round. The child was having bloody tears from lips and inside the eye and was also having blood discharge from around the nail beds. After this episode, we started searching the literature to know the rarer causes of hemolacria in childhood. The entities that we came across was Munchausen syndrome by proxy, Gardner-Diamond syndrome or psychogenic bloody tears, and idiopathic hemolactia. To rule out Munchausen syndrome, we sent the sample of tears for cytopathological examination, which showed it contained actual red blood cell, and the episode happened in front of us during the round. So chances of Munchausen syndrome was very less. And there was no history of spontaneous painful bruises, so we could not match this case to Gardner-Diamond syndrome, which is also a very rare entity characterized by painful bruise and purpurea during the episodes of emotional stress, almost always associated with hemolacria. So before diagnosing these two cases of idiopathic origin hemolacria, we decided to go for a thorough psychiatric evaluation of the case, though the child did not have any signs of psychiatric manifestations. The psychiatric opinion on this case, the psychiatrist observed the child had depressed mood with anxiety and referred the child to the psychologist for childhood apperception test. The childhood apperception test is a projective personality test to assess the personality and any hidden emotional disturbances and psychological health. It tells us about the child's needs and drives, anxiety, conflicts, and fear. The CAT examination for this child shows the child is not satisfied about herself and who is mentally weak and crippled and vulnerable to stress. The conception of environment, that is the family and surrounding, is stressful and fearful. So the psychiatrist diagnosed this to be a case of generalized anxiety disorder and subclinical depression and advised tablet amitriptyl and tablet clonazepam. As we had excluded all possible causes of hemolacria, our final diagnosis for this case is psychogenic hemolacria, occurring in an episode of emotional stress manifesting as bleeding tears. We discharged the patient with treatment advised by the psychiatrist and followed up the patient after 1 month and 3 months. And the child did not have any recurrences after that, which further confirms our diagnosis of psychogenic hemolacria. Psychogenic hemolacria is a very rare entity in itself. As few as 2 to 3 cases are reported in India, mainly seen in females. Pathophysiology is not clearly understood, but it is postulated that during the episodes of stress, there is excess catecholamine released in the blood. And the RBCs get sensitized to this excess catecholamine, known as autoerythrocytic sensitization, together with increased fragility of the capillary, leads to this psychogenic hemolacria. The outcome of these cases are usually good with appropriate treatment. There are few case reports previously noted of psychogenic hemolacria. The first case report is from Kolkata in a 14-year-old girl who had intermittent episodes of bloody tears, who is diagnosed as a case of major depressive disorder with generalized anxiety. The second case report is from 1984, where a child of 15-year-old have psychogenic hemolacria occurring with the stress of house examination. The third report is from Riyadh, and where a 12-year-old healthy girl had history of hemolacria after fight with her sibling. So what is the take-home message from this presentation? That hemolacria itself is a very rare disease, but when we encounter such disease, we should always look after the every possible causes of hemolacria in a stepwise approach to rule out any hidden etiology. As psychogenic hemolacria is a separate entity, and with the diagnosis of psychogenic hemolacria, if we start the appropriate therapy, the quality of the life can be improved a lot because it has good prognosis. Thank you.
Thank you, Moinak. So again, I request audience to put questions in the chat box. We will try to answer all of them. Now I am going to fifth case, a tale of regression. And here speaker is Sriti Surana. So Sriti, please start.
Priti is muted.
Some audiences are requesting to show the video again. So we are running the video, then we will start our fifth case. Next,
Sir, we can see here there is bleeding from and around the eyelids and from the eyes. So you can concentrate on the arrow, which clearly shows there is bleeding from the eyes and around the eyelids. Sir, here you can see there is active bleeding coming from the nail bed, which occurred during our rounds. Thank you, sir.
so we are going to our fifth case, a tale of regression. And speaker is Dr. Sriti Surana. So Sriti, please start. All questions we are answering in the chat box. এটা আবার কি হলো? স্টার্ট, এটা কি হলো? এই হ্যাঁ হ্যাঁ
Good afternoon, everybody. My
Hey.
name is Dr. Smriti Surana, and I'm here to present a case under
Am
the
I-
name of Tale of Regression. 2-year, 6-month-old male child from Veranda presented with recurrent episodes of convulsion for 1 day and regression of achieved speech and ambulation since 18 months of age, along with loss of eye contact and poor response to call for the same duration. The child presented with history of recurrent episodes of generalized tonic-clonic convulsions for last 1 day, lasting for 2 to 3 minutes each. There was no history of fever, vomiting, trauma, or similar episodes in the past. Child was developmentally normal till 18 months of age, after which mother noticed loss of eye contact and decreased response to call, followed by gradual regression of the achieved speech and ambulation. He was completely bedridden for the last 5 months. Mother also complained of repeated stereotypical movements of the hand for last 1 year, along with intermittent crying spells at night. Parents had visited various homeopathic and local physicians in the past, and child was on some homeopathic medication for the same. Perinatal history was uneventful except for history of respiratory distress, which required SNCU admission for 3 days. Child was able to walk with unsteady gait till 18 months of age, after which there was gradual regression of the motor milestones. He was able to reach out for objects earlier and could say Ma and Baba, which later regressed to cooing. Child could also clap and wave goodbye, but now was unable to do so. He was on mixed diet, taking adequate calories, immunized up till date, and he was the firstborn out of non-consanguineous marriage. There was no significant family history. On general survey, child was lethargic and disoriented. Height was between 75th and 90th percentile. Weight was between 50th and 75th percentile. Head circumference was 46 centimeter, which fell on 3rd percentile. Rest of the measurements were within normal limits. Facies was normal. There was absence of pallor, cyanosis, clubbing, icterus, or edema. Vital parameters were stable. Head to toe examination revealed microcephaly. On light examination, pupil showed bilateral dilatation. On central nervous examination, GCS was found to be 8/15. Tone was increased in all forelimbs. Power could not be elicited. Deep tendon reflexes were brisk in all forelimbs. Plantar was bilateral extensor. Ankle clonus was bilaterally present. Meningeal stimulus was present. Primitive reflexes were absent. Cranial nerve examination and cerebellar signs could not be evaluated. There was no signs of autonomic instability. Other system examination were within normal limits. On day 1, child was started on injection ceftriaxone and loading dose of phenytoin was given. Blood for complete blood count, sodium, potassium, urea, creatinine, LFT, ammonia, and lactate was sent, and eye refer was done. On day 2, child had episodes of myoclonic jerks and half-loading dose of injection phenytoin, followed by loading dose of injection valproate and major defect, along with bilateral optic atrophy. Blood reports and CSF were within normal limits. On day 3, we noticed this myoclonic jerks involving all forelimbs. On day 2, we noticed this myoclonic jerks involving all forelimbs. On day 3, there were no further episodes of convulsion. Feeding was started by orogastric tube. MRI and EEG were done and reports were awaited. Blood ammonia and lactate level came out to be normal. On day 5, we found the MRI report which showed bilateral symmetrical volume loss of cortical gray matter in the supratentorial region involving frontal, temporal, parietal, and occipital areas, causing prominence of the cisternal and sulcal space with resultant dilatation of the lateral ventricle. Bilateral hippocampus appeared atrophic. Sleep-induced EEG was within normal limit. So in the background of neuroregression and convulsions and microcephaly spasticity, wrist deep tendon reflexes, myoclonic jerks, optic atrophy, along with MRI brain showing cerebral atrophy, a provisional diagnosis of neurodegenerative disorder, most probably gray matter disorder, was made, which could further be subclassified based on the area of involvement into cortical cerebellum, along with them being normal on the MRI. Cerebellum and basal ganglia diseases were ruled out. As hepatosplenomegaly was absent, MRI Hepatosplenomegaly was absent. Storage disorder was ruled out. So we were left with the 7 choices. Tay-Sachs disease was ruled out because of absence of cherry red spots and macrocephaly. Rett syndrome was ruled out because as it is an X-linked dominant disease, it is almost exclusively present in females. In the absence of sparse kinky hair and hypotonia, Menke-Kinki's hair disease was ruled out. Leigh disease was ruled out as there was absence of respiratory symptoms and hypotonia. Deep tendon reflexes were brisk and there was normal blood lactate, urea, and creatinine levels. So we were left with neuronal ceroid lipofuscinosis, subacute sclerosing panencephalitis, and HIV. On day 6, blood for HIV 1 and 2 was sent along with viral load. CSF was sent for IgG antibody against measles virus and genetic study was planned. Child was gradually shifted to oral antiepileptics and orogastric feeding was continued. There was no improvement in sensorium. On day 12, HIV 1 and 2 along with viral load report came which turned out to be negative. CSF for antibodies to measles virus was also negative. Genetic study of both the parents showed heterozygosity for MCL1 and the child was homozygous. Thus, a final diagnosis of infantile type of neuronal ceroid lipofuscinosis was made, which is a group of inherited neurodegenerative lysosomal storage disorder characterized by visual loss, progressive dementia, seizures, motor deterioration, and early death. There is intracellular accumulation of fluorescent lipopigment, ceroid, and lipofuscin. There are basic 3 broad types of NCL. Infantile type, where the symptoms typically begin in the first year of life as myoclonic jerks, intellectual deterioration, blindness, optic atrophy, brownish discoloration of the macula, and cerebellar ataxia. There is recessive mutation of gene for lysosomal enzyme palmitoyl protein thioesterase 1, which is present on chromosome 1p32. Death occurs in the childhood. In late infantile type, a previously normal child develops seizures between age of 2 to 4 years, followed by dementia, ataxia, and progressive loss of visual activity and microcephaly. And in the juvenile type, which is more common variant of the infantile or late infantile type, due to autosomal recessive mutation in CLN3 gene, child is normal till 5 years of age, followed by progressive visual loss, retinal pigmentary changes, rapid decline in cognition and personality, motor incoordination, myoclonic seizures, and impaired ambulation. In conclusion, a precise history confirms regression of developmental milestones and neurological examination localizes the processes within nervous system. Although outcome of a neurodegenerative condition is usually fatal and available therapies are often limited in effect, it is important to make correct diagnosis so that genetic counseling may be offered and prevention strategies can be implemented. Bone marrow transplantation and other novel therapies may prevent the progression of disease in certain pre-symptomatic individuals. Thank you.
Thank you, Siddhi. So, if you have any queries, you can put in the chat box. We are answering. And now we are going to present one of the rarest of rare cases where prognosis is very good. So, case is orange urine, curious case of a boy who suffered. And speaker is Dr. Shankar Narayan Mishra. Let's see the case. What happens?
Sir, am I audible? Okay. Good afternoon, my respected teacher, professors, and my junior, seniors, and colleagues. I am going to the case directly. My case is orange urine, curious case of a boy who suffered. Myself, Dr. Shankar Narayan Mishra, third year postgraduate trainee, Burdwan Medical College. Okay. 3-year, 5 months old boy, Sheikh Aryan from Tildanga, Burdwan, admitted to our hospital on 21st March. An infant was mother. The boy had a chief complaint of persistent orange discoloration of urine for last 1 month. There is no history of fever, pain abdomen, no history of any urgency, frequency, or burning sensation during micturition. No history of any drug intake or any coloring food or coloring agent or dye intake. And also, there is no history of trauma or similar past illness. The boy was treated by the local physicians who prescribed several medications and investigations, but no clue to the diagnosis could be derived. The family members thought the discoloration was due to the dehydration and tried to correct it by giving extra fluids. Eventually, the urine output increased, but the orange discoloration persisted. We stopped all the ongoing medications and kept the child for observation. Examination finding: the child was alert, conscious, cooperative, temperatures were normal, no icterus, pallor, cyansis, clubbing, edema, jaundice. Pulse rate was 80 per minute, regular, normal in volume, no radioradial or radiofemoral delay, no signs of dehydration, and blood pressure was normal, 94 by 70 millimeter Hg at right upper limb. CVS, respiratory system, and power abdomen was nothing significant. There was no significant organomegaly or no CNS deficits. There was no history of DDM also, and no seizure disorder in the past. Anthropometry: weight was 15 kg, falling at 50th percentile, and height was 100 centimeter. It's falling just above the 50th percentile according to the IIP growth chart. So the initial differential diagnosis were dehydration, acute viral hepatitis, acute glomerulonephritis, G6PD deficiency, urinary tract infection, and porphyria. So we sent the investigation to roll out our preliminary diagnosis that showed hemoglobin 12 gram percent, WBC 13,000, platelet 4,68,000, and urine REME, routine examination and microscopic examination showed albumin 1 plus, past cell 5 to 8, and RBC 0 to 2 per hyper fluid, and no bile salts or bile pigments. And liver function test was normal. The USG whole abdomen showed no abnormality. Urine culture sensitivity that showed during the on the admission day that showed no growth on day 4. And we also measured 24-hour urine output to look for any dehydration, but it was found to be normal. Urine output was at the rate of 4 ml per kg per hour. So then we sent the second line of investigation, the G6PD, that is found to be also normal. Serum C3, ASO, CRP, all were normal. And to rule out porphyria, we sent urine for porphobilinogen, that is found to be negative. And ICTC also non-reactive. As all the investigation yielded normal results, we stand clueless to the mother even at 7th day of admissions. Then we search for some literature. There's one literature showing an infant with orange color urine published at PubMed Central in the year 2010. That's showing the orange discoloration of urine is associated with growth of Citrobacter shedlaki infections. So we send urine REME and culture again with special mentioning to use any special media for Citrobacter growth, and the child was started with syrup co-trimoxazole at the rate of 15 mg per kg per day on day 8 of the admission, empirical, following the literature. Then the miracle happens. The urine became crystal clear on day 3 of oral co-trimoxazole therapy, and urine REME has also showed significant improvement. Past cell has decreased to 1 to 2 for hyperbuilt, and RBC became nil. And on day 4 of antibiotics, the report came. The urine culture showed Citrobacter species growth after 72 hours of incubation, which was sensitive to cefotaxime, ceftriaxone, and co-trimoxazole. This was the report. The patient was discharged with advice to continue syrup co-trimoxazole for another 3 days and follow-up done with USGKB, which was found to be normal. Discussion: Citrobacter is known to inhabit human and animal intestines, water, soil, and sometimes food. It rarely colonizes in the urinary bladder of infants and immunocompromised children. But in our case, the child was not immunocompromised. Citrobacter shedlaki produces indole compounds from the tryptophan and imparts to an orange color of the urine. This was the case article, research article published in PubMed Central as an emergence of Citrobacter infection in hospital-acquired patients, hospital-acquired infections. But in our case, the boy was not previously admitted to any hospitals. These are my references. Thank you.
So thank you, Shankar. Now we have 2 small cases, and 7th case is all questions will be answered. You can put in the chat box. We are answering one by one. So our 7th case, an unwanted guest in the mediastinum. An unwanted guest in the mediastinum, and speaker is Dr. Abu Obaid. So Abu, start.
Good afternoon, everyone. Today, I am presenting a case. My topic was an unwanted guest in the mediastinum. Myself, Dr. Abu Obaid, second year PGT, Department of Pediatrics, Burdwan Medical College and Hospital. So a 3-year, 8-month-old boy came with mainly chief complaint of chest pain or rather discomfort for last 1 month, cough for 5 days, and respiratory distress for last 2 days. On history of present illness, patient presented with right-sided chest discomfort for last 1 month, intermittent flicking in nature. Pain was localized. Non-radiating, non-increase upon exertion, not associated with sweating or palpitation. Mother also complained of intermittent non-productive cough for last 5 days. Cough did not increase on supine position. No history of fever, vomiting, contact with TB or COVID. Mother also complained of respiratory difficulty for last 2 days, gradually progressive in nature, not increase on exertion or in supine position. There was no history of cyanosis and dysphagia, decreased urine output. And past history was significant as child had recurrent episode of cough and coryza, requiring 1 episode of hospital admission at age 2 years, where child was diagnosed as LRT and treated with antibiotics. Parental history, uneventful. Developmental history, similar to his parent. Immunization history, immunized till date. And family history, no history of similar illness in the family. So this is our case of interest. As general survey, patient was alert and conscious, face is normal, anthropometry, height normal, weight 12 kg, less than 3rd percentile. Upper segment and lower segment ratio 1.1, head circumference 50.2 centimeter. Vitals, pulse 108 per minute, regular, normal volume, no radioradial or radiofemoral delay. BP 92 by 65 millimeter of Hg, temperature 98 degree. Respiratory rate was high, 58 per minute, regular, abdominothoracic. SpO2 94% with moist O2. And general survey continue. Pallas, cyanosis, icterus, clubbing, and edema was absent. Neck not engorged. Lymph node not palpable. On systemic examination, respiratory system, chest is normal in shape, move with respiration, bilaterally symmetrical. There is no pigmentation, mass, visual pulsation, surgical mark, or any deformity. Trachea deviated to left side. Chest expansion is normal on both sides. Vocal femmitus is decreased on right side. Vesicular breath sound present. Decreased air entry on right side, and bilateral wheezing was present. On CBS examination, S1 and S2 audible, no murmur or gallop. Other system was normal. No abnormality there. So we provisionally diagnosed as ARI or pneumonia and treated with accordingly like nasal O2, proper position, antibiotic, bronchodilator, and analgesics. So the investigation result was come, and the CBC was shown that hemoglobin was 11.2, total leukocyte count 11,700, platelet adequate, and CRP less than 6 milligram per liter. Now the chest X-ray come, and we show a round mass in the mediastinum. As we found the mass, we referred the case to a chest physician for opinion, and he was also diagnosed as mediastinal mass, mostly anteriorly located, and advised for USG thorax, CCTA chest, and echocardiography. USG thorax and echocardiography result was come, and they both are normal. But the CT result when come, we found a large cystic SOL measuring, this is the SOL measuring 6.5 into 6.5 into 7.3 centimeter square with peripheral enhancement and in the mediastinum. So that we take the video of the mediastinum, and if we carefully note it, then we can see the mass was connected with the vertebra, as we can see, and the CT result also came, and we found a large cystic SOL measurement of 6.5 into 6.5 into 7.3 centimeter square with peripheral enhancement noted in the posterior plus middle mediastinum, slightly right to the middle with deviation of the trachea to the left, and associated segmentation defect noted in the upper thoracic vertebra with demonstrable connection to the above described lesion with the spinal canal. And there was focal consolidation noted in the anterior segment of the right upper lobe. The impression of the CT chest was anterior mediastinal meningocele with mass event. And we found similar article was published in 2024. Isolated true anterior thoracic meningocele is one of the rarest, usually and generally associated with neurofibromatosis type 1. Most of the reported thoracic meningocele are not strictly anterior in location, but also lateral or anterolateral. they also report in this case as anterior thoracic and with no associated generalized mesenchymal dysplasia. So my final diagnosis was this is a case of anterior mediastinal meningocele with mass effect in a 3.8-year-old boy. Thank you.
So thank you, Abu. Now we are going to our last case. It's the cherry on the cake. Interesting case. And speaker is Dr. Subho Rai. So Subho, please start.
Good afternoon, everyone. I am Dr. Subho Roy, second year PGT, Department of Pediatrics in Burdwan Medical College and Hospital. My today's case is cherry on the cake. This is the case of our interest. A 2-month-old male child from Paschim Burdwan presented to us with chief complaints of yellowish discoloration of eyes, yellowish urine, and pale colored stool for last 1 month. And he was also not gaining weight for last 1 month. And there was no history of fever, vomiting, convulsion, bleeding from any other side, or any rash. His birth weight was 3 kg. All other histories are within normal limits and non-significant. In anthropometrical examination, we found his weight to be 3.1 kg, which is less than 3rd percentile for his age. Length was 57 centimeter, which is more than 15th percentile, and head circumference was 38 centimeter, which was also more than 15th percentile. And all other findings were within normal limits. On abdominal examination, we find a huge hepatosplenomegaly. Liver was enlarged in size, 4 centimeter below subcostal margin along mid-clavicular line, and firm inconsistencies. Spleen was 6 centimeter below subcostal line along splenic axis and was also firm in consistency. Examination of other systems are within normal limits. So at this point of time, we thought this case as neonatal cholestasis and started treating with IV antibiotics, injection vitamin K, tablet ursodeoxycholic acid, all the fat soluble vitamins and water soluble vitamins in double doses. Here are some differential diagnoses of neonatal cholestasis. Then here are some reports. His complete blood count showing some degree of anemia, which may be due to physiological anemia at this age. MP, MPDA was negative. Blood culture was also negative. In LFT, we found conjugated hyperbilirubinemia. Serum glucose was 98 milligram per deciliter. Urea was 24. Creatinine was 0.6. PT was 13 second and APTT was 30 second. Thyroid profile, G6PD, urine for REME, all were within normal limits. TORCH screen, urine culture are also negative, and serological markers for hepatitis B and C are non-reactive. On abdominal USG, we found liver span of 7 centimeter, poor texture with inflammatory changes. So with this history and clinical findings and USG reports, we planned for liver biopsy and HIDA scan. In the meantime, as we are to exclude possibility of any congenital infection and or metabolic disorder, we sent the baby for ophthalmological examination. And here we found cherry red spot on fundoscopy. So at this point, with such clinical presentation and investigation reports and clinical findings, we initially thought the baby as Niemann-Pick's disease, but we also have the possibility of Gaucher's disease in the back of our mind. So we sent enzyme study for these two diseases, and we found beta glucosidase enzyme activity was deficient and sphingomyelinase enzyme activity was normal. So with these findings and reports, my final diagnosis is Gaucher's disease, that is of infantile type in a 2-month-old boy with features of cholestatic jaundice and hepatosplenomegaly. Now here are some points about 3 types of Gaucher's diseases. So about the investigation of Gaucher's disease, in suspected cases, we should go for bone marrow study, and most of the cases will find Gaucher's cells. But in this case, as the parents didn't give consent for further invasive procedures, we couldn't do bone marrow study. The diagnosis was confirmed by acid. It can also be confirmed by specific gene mutations. Prenatal diagnosis also can be done by enzyme study and specific family mutations in chorionic villi or cultured amniotic fluid cells. Now here are some points about treatment. First is enzyme replacement therapy, which is standard for type 1 Gaucher's disease. At the dose of 60 international unit per kg administered IV infusion every other week, most of the symptoms like organomegaly, hematologic indices and bone pain are reversed. But in case of type 2 disease, if there is neurological augment, the enzyme replacement therapy cannot reverse the course. And in type 3, it can regress the organomegalies. And the other treatment options are oral substrate reduction agents and bone marrow transplant. Bone marrow transplant is curative but associated with significant mortality and morbidity related to transplant. So here are some differential diagnoses of cherry red spots. Now the take-home message is that most of the storage disorders are not curable, and even there is very little treatment options available in our hands at present. But the main aim of diagnosing a storage disorder is that we can explain the course of the disease to the parents and we can understand our limitations. Thank you.
Thank you, Subho. So this was our last case. And I thank all the audience for patience hearing. And now I hand over the platform to our respected Susmita Madam. Madam, please.
Thank you very much, Dr. Kosov, and to your whole team, to the whole team of Burdwan Medical College. We have had a series of really excellent, very rare, very well worked up cases today. And I think most rewarding is that it was all very brisk and we have kept to time as well. So while the judges are making up their mind to announce the first and second prizes, or rather the first and second positions, we will be awarding certificates from WBAP. Can I ask Dr. Indranil Chaudhary to announce further programs for this month? And then Dr. Abhijit Datta, if you have anything further to say, Abhijit Datta.
Yes, for this month, after today's program, we have some other programs also. For example, on 1st of May, we have a rheumatology conference and in the Park Hotel in Kolkata. After that, we have also some other big conferences. For example, the Hooghly conference is on 29th of May. But more importantly, the first ECD in Kolkata will be in West Bengal, will be held on 28th of May in Hooghly. So I would request all the participants to please come and do the workshop in Hooghly. This is the first workshop in West Bengal of ECD. So that's all. Over to Sushmita Di.
Can I just mention two other smaller meetings on the 16th of April? We have a interactive workshop on autism, which will be held in Apollo Hospital. And on the 24th of April, we have a nephrology masterclass. Again, this will be an interactive case-based program, and it will be held in PLS area. So please contact the WBAP office if you would like to have any details of these programs and details of registration, etc. Our next clinical meeting will be on the 28th, last Thursday of the month in RKM. And then we have a Legends program towards the end of the month. So the date of that will be announced subsequently. Thank you, judges, and Dr. Abhijit Dotto, your decision.
No, I am actually not the judge. Today's judge is Dr. Ashok Dotto and Dr. Shike Ghosh. Hello, Ashok Da, can you hear me? Ashok Da, শুনতে পাচ্ছেন?
Ashok Da, you're muted. Please unmute.
Audible আমি শুনতে পাচ্ছি. We'll send the result after discussion. So it's Shike Ghosh. Okay.
আচ্ছা এখন হয়ে গেলে সবাই জেনে যেত হবে নাকি shall we wait for 2 minutes?
I must discuss with Dr. Chandrakant.
Acha, then we will announce it in our WBAP WhatsApp groups.
You can announce in the next meeting also.
We will announce in the next meeting, and we will also announce it by WhatsApp in our groups.
That will be right, so that everybody will join in the next meeting also.
Okay, and
we will announce after discussion with Dr. Shike Ghosh.
ঠিক আছে. And the certificates will be also sent to you.
Okay.
Yes, sir. Yes, sir.
Okay.
So
thank you everyone.
Just 1 minute.
Yes.
We have another program in Purulia on 17th of this month. The program name is Tagging the Bugs. This time the speakers are Dr. Indranil Chaudhary and myself. So that will be on 17th, Sunday.
Venue ta bole di. Venue and timing.
Title is Tagging the Bugs and venue is Purulia. Venue actually, Indranil, can you hear me? Indranil.
I think Indranil bodhoy nei. ঠিক আছে তাহলে we will announce by our WhatsApp.
It is already there in the calendar.
ঠিক আছে আর anyone else anything to say? চন্দ্রকান্ত দা কিছু বলবেন?
হ্যাঁ বলছিলাম যে কৌস্তব দাকে স্যারকে নমস্কার স্যার এত ব্রিলিয়ান্ট yes
thank you
many uncomplicated uncommon cases have been you have been given.
Thank you,
so many thanks to you.
Thank you.
So it is a brilliant session. Now WBP has given some opportunity to youngster to give this seminar. So after discussing Dr. Dotto, we can give the results. Okay?
Yes, sir. Thank you.
Thank you, everyone.
So we are leaving, madam.
Susmati, thank you.
We are leaving, madam.